Welcome, everybody, to our session this morning called Data and Perspectives. Clinical investigators discuss the emerging role of AKT inhibitors in the care of patients with prostate cancer. I'm your moderator and host for this session, Dan George, and I'm joined with two of my esteemed colleagues and friends, Dr. Leonard G Gomella and Evan Yu. Lenny's the Bernard Goodwin Professor of Prostate Cancer and Chair, Department of Urology at Jefferson. And Evan is our Section Head of Medical Oncology and Clinical Research Division at the Fred Hutch. These are some of the faculty disclosures for our faculty. This is for Dr. Gomella, for Dr. Yu, for yours truly. And then we're going to be joined virtually. We have some pre-taped recordings from a number of faculty. Dr. Antonarakis in his disclosures, Dr. Professor Fazazi in his disclosures, and Dr. Hope Rugo, who's a breast cancer expert from UCSF, will be giving us some perspectives as well from another disease setting. We have commercial support for this activity from AstraZeneca Pharmaceuticals and Research to Practice. This is a CME program. We have a planning committee, staff, and reviewers that have no conflicts of interest to disclose. This is an educational activity, and it contains discussion of non-FDA-approved uses of agents and regimens. So just keep that in mind and just refer to prescribing information for each of the products that we discuss. Okay, so with that, we're going to jump in here. Let me just introduce the consulting faculty that you'll see. We have three of them. Some will be very familiar to you all. Dr. Emmanuel Antonarakis is an endowed professor of medicine at University of Minnesota and a prostate cancer expert, as is Dr. Professor Karim Fazazi, who's head of service and professor at the Institut Gustave Roussy in France. And then Hope Rugo, who you may or may not be familiar with. She is a director of the Women's Cancer Program and division chief for breast medical oncology at UCSF. And of course, our own beloved Dr. Love, who couldn't join us this afternoon, whatever time zone you're in, but just recognize that he will be part of these videos and also has had a tremendous input into this program structure. So these will be the topics playlists, if you will, that will intersperse throughout this program. So you'll have obviously the live content, but then we'll also have these short videos to help add and fill out some of the content and perspectives. So we have three modules. We have three speakers. We'll each give one module. We'll start off with the current treatment landscape for metastatic hormone-sensitive prostate cancer by Dr. Gomella, then followed by the clinical implications and appropriate strategies to identify PTEN deficiency in prostate cancer by Dr. Yu. And then I'll give a talk on emerging role of AKT inhibition in metastatic hormone-sensitive prostate cancer. So with that, we'll start here with Lenny. Take it away.
Great. Well, Dan, thank you. Thank RTP and the sponsors for doing this program during our AUA. My first talk is really going to be to set the stage about where we are today with metastatic hormone-sensitive prostate cancer. And these are the four areas we're going to hit. We're going to talk about management, long-term outcomes. We're going to talk about specific factors in the selection of therapy for men with metastatic hormone-sensitive prostate cancer. And lastly, we're going to wrap up with some of the trials using proven strategies that we're moving from castrate-resistant back to hormone-sensitive prostate cancer. So this is a various form of a kind of flow chart of prostate cancer. These are all modified from Dr. Howie Scher. And where we are on this flow from left to right is sort of in the middle, where we're talking about clinical metastasis in the non-castrate state. In other words, the man who normally presents with metastatic prostate cancer and who is hormonally intact. So we always look to the NCCN guidelines when it comes to various treatment approaches. And what I'm showing you here is the approach to M1 castrate-sensitive prostate cancer. And it's very important to break this presentation down of the patient between high volume and low volume disease. And the first thing we'll talk about here is the patient with low volume disease. And again, most of the time the literature would suggest that it's less than 4 or 5 metastatic lesions, either visceral or in the skeleton. If you have low volume synchronous presentation, we're not going to talk about metachronous presentation for patients who develop metastasis later. This is all about the initial presentation. You can see you have various ways to go using a lot of the androgen receptor pathway blockers along with ADT. And again, ADT is the platform. You can also use docetaxel in these patients, again, along with an androgen receptor pathway blocker. And the other thing that's a little bit different about low-volume hormone-sensitive prostate cancer, there is a consideration to radiating the primary prostate tumor. For high volume, we don't do that, but for low volume, that's an option. So here we have the high-volume patients. Usually they're synchronous, occasionally metachronous, and this is where we start to see more of the doublet and triplet. With high volume disease, we'll talk about the great data that we have on adding now 3 different agents into the treatment paradigm of these patients. However, you can skip the chemotherapy. You can de-escalate a little bit. Again, as we'll talk about near the end, you got to customize all of these treatments so you have many options available. And at the end of the day, the provider needs to figure out, okay, what's the best for this particular patient, considering their age, comorbidities, other diseases. So the big difference here in low volume versus high volume is it is normally not recommended to treat the primary tumor with high volume disease with radiation therapy. What about long-term outcomes? And this is really one of the most important papers that I've come across recently from Dr. Agarwal, who basically looked at a series of studies of prostate cancer over the years. And basically, most textbooks will say when you have metastatic prostate cancer, your life expectancy is about 2.5, 3 years. Dr. Agarwal went back and reviewed data and really is now showing us everything that we are feeling in the clinic, that men are actually living longer and longer. Dr. Agarwal was actually able to show us that many of these men now, their median survival is up to 70 months. And what we're seeing here is the impact of other therapies that have come along in the last 10 years, and you see many of them here. These are then added on to men with metastatic prostate cancer. And again, we're really seeing an extension in life thanks to these new therapies. Treatment choices for metastatic castrate-sensitive prostate cancer. ADT is the foundation. Dose intensification has been with us based on very important clinical trials. Doublet therapy is an androgen receptor pathway blocker such as abiraterone, apalutamide, or enzalutamide. Triplet therapy adds chemotherapy onto those regimens. And again, radiation therapy in the guidelines is really limited to patients with low-volume disease. The first inkling that we had that extending doublet therapy to triplet therapy really came from the CHARTED trial, which is now about 7 or 8 years old. And basically, it showed that adding chemotherapy to men with low-volume disease didn't really add anything except for toxicity and expense. If you've got high-volume disease, however, this has now become one of the tenets of triplet therapy, where adding chemotherapy onto these men is very, very helpful. So here's some most recent data that we have from about 2013. Men who received first-line metastatic castrate-sensitive prostate cancer, it was ADT monotherapy. That was it. Over the next 5 years, we see a major shift to androgen deprivation therapy plus a novel hormone therapy or androgen receptor pathway blocker. So we're seeing a significant shift from monotherapy for men with metastatic castrate-sensitive prostate cancer to multi-agent therapy. What about the factors that we use when we decide how we're going to treat an individual patient with metastatic castrate-sensitive prostate cancer? Well, again, we've had a lot of agents added in our portfolio. They basically fall into the primary ADT packet of GnRH agonists, the traditional ones we use, such as Leuprolide. These been around since the 1980s, only available as an injection, can be given usually monthly, 3 months, or every 6 months. First-generation anti-androgen may be added to these men to block the testosterone surge. And the other thing is, if you're going to use intermittent therapy, slower testosterone recovery after you stop the medication is a hallmark of the GnRH agonist compared to the GnRH antagonists, which are either available at monthly injections. However, after about a year of treatment, you really do need to ship the patient over to a GnRH agonist. Rapidly suppresses the testosterone, no need for a anti-androgen. There is some suggestion that the oral agent, as the GnRH antagonist, Regulolix, may reduce cardiac risk, but again, we have both injectable and oral agents in this area. What about the treatment selection? Again, the choice of agent depends on a lot of factors, what you're going to add on to the ADT, and some of the factors are shown here. Each of them have some unique characteristics with them, either from a cost standpoint or from an administrative standpoint. But I want to point out that the abiraterone and the docetaxel now are available to us along with darolutamide as triplet therapy, which has been shown to be very beneficial. Again, as providers, we understand the adverse events which each of these different medications can be associated with. And again, this comes down to where you customize your ADT plus your second agent. Again, try to customize things for individual patients based on either general AR, androgen receptor pathway blocker inhibition, or the more specific agents. This, to me, I think is a very telling slide, looking at doublet therapy, where we have outstanding clinical trials, Latitude, Stampede, Arches, and Titan, that really show us that now adding a second agent in these men with metastatic hormone-sensitive prostate cancer really reduces the risk of death. But I think the big breakthrough that we've seen in the last 2 or 3 years based on the PEACE-1 trial and the ARASENS trial is the fact that triple therapy, in other words, abiraterone, ADT, and docetaxel, or darolutamide, ADT, and docetaxel really has a significant improvement in survival. Here's lining up ADT alone, the doublet therapy, and the triplet therapy. And again, if you have the appropriate patient, you can see the dramatic improvement in triplet therapy, adding docetaxel onto the ADT and an agent such as abiraterone. Lastly, we have a lot of ongoing randomized phase 3 trials in metastatic hormone-sensitive prostate cancer. This is just a short list that you see here of adding additional agents, but this is based on biomarkers. If you look at, we're going to be talking a lot about PTEN and PTEN deficiency, but these other biomarkers out there, such as HRR gene alterations and a PSMA positive scan. I consider a PSMA scan to be a biomarker for someone who might be able to go on to some agents such as Pluvicto and the other agents. We're going to be talking a lot about this as a biomarker for PTEN deficient metastatic hormone-sensitive prostate cancer. My colleagues are going to fill a lot of details on these AKT signaling pathway inhibitors. And again, these are the ongoing biomarker trials that we have in the space of metastatic castrate-sensitive prostate cancer. Again, looking at genetics, looking at imaging, and looking at PTEN staining. So the bottom line is dose intensification with these novel agents is really improving survival. Side effects need to be considered. Despite multiple clinical trials, the acceptance rate of multiple doublet or triplet therapy is actually quite low, and many new trials include biomarkers in this space, and trials evaluating things like lutetium-177, PARP inhibition, and novel agents in metastatic hormone-sensitive prostate cancer are coming down the pike very quickly. So again, thank you very much, and I hope you found that presentation useful for the follow-ups.
Very, very well done, Lenny. Thank you for really setting the stage for us in terms of where we are in 2025 with our standard of care treatments and the nuances and complexities around those treatment choices. Now for an additional perspective here coming from Dr. Vazazi in France, we'll tee up a short video.
Good afternoon, everyone. I'm Neil Love from Research to Practice, and special thanks to Dr. George for allowing us to create sort of a meeting within a meeting today, interdigitated with the faculty presentations. To do this, we first enlisted prostate cancer investigators Dr. Karim Vazazi and Emmanuel Antonarakis to query the faculty about the 2025 version of what I would call first-line systemic treatment of metastatic prostate cancer and the future role of targeted treatment, such as PARP inhibitors in this setting. Next, I met with noted breast cancer investigator Dr. Hope Rugo, who's had an important role in the introduction of the AKT inhibitor capivasertib into the treatment of hormone receptor-positive breast cancer, to talk about her experience with CAPI, as we call it, not only to help prepare our urology colleagues for practical issues they may soon be facing, and perhaps even more importantly, to show how the use of AKT inhibition is a model of what happens very frequently nowadays in oncology, the introduction of a new class of targeted agents with their own important considerations. We'll finish out with some questions about what's on the horizon in prostate cancer.
So my question to you guys is, how do you envision treatment of patients with metastatic castration-sensitive disease in the coming, say, 2 years? I'd be curious to hear from you whether you think we should treat a different way patients with metastatic hormone-sensitive disease who relapse after local treatment versus those with de novo metastatic castration-sensitive disease. I'd be curious to hear your thoughts about the scenario that we're now frequently seeing in the clinic of patients who relapse after local treatments, so biochemical failure. Patient has access to a PSMA PET, and here you go. We see a few bone metastases or lymph node metastases, but still, PSA is rising fast. What is your practice? Local treatments, intensify systemic treatment, conventional systemic treatment, or no, not at all using a systemic treatment? Do you guys think we should use PSA 6 to 8 months, say, after we have started systemic treatment in metastatic disease to better tailor all the treatment burden? Maybe de-escalation in good responders, maybe further intensification in patients who are poor responders.
Excellent. Well, thank you, Dr. Vazazi. And let's jump into some of these questions, because I think, there's no better way to address these issues than framing it in the context of a patient. And so here we have, say, I'll just start it out, Evan, a 75-year-old man with de novo metastatic hormone-sensitive prostate cancer, multiple asymptomatic bone-only metastasis, maybe on PSMA PET, as Dr. Vazazi put out. What's your thinking? How do you approach a case like that?
Yeah, I mean, Dr. Vazazi asked a lot of relevant questions. Not one, but multiple relevant questions. So I'm going to address what you just asked me, the first one. Well, in this day and age, the most important criteria we look at to help us determine treatment is really, does the patient have de novo synchronous metastatic disease, that means they present with metastatic disease, or do they have recurrent disease or metachronous disease, which means maybe they had radical prostatectomy or radiation of the prostate and years later they relapsed. It's very clear that prognostically there's a difference. Those who present with de novo metastatic disease have a worse prognosis. And when you're thinking about things like treatment intensification, especially when you're thinking chemotherapy with docetaxel, that's a very, very important factor. But volume disease is very important as well. And I remind you that at this point in time, volume disease is still defined by conventional imaging, CT scans, bone scans. And it's the presence of visceral metastases, like liver metastases, that puts you into a high volume, high risk category. And or if you have bone metastases, then or bone and lymph node, then it's 4 or more bone metastases with at least one outside the axial skeleton and the appendicular skeleton, puts you into a high volume or high risk category. And so those are the factors I look at. With PSA PET, as you asked, Dan, I think that's really important because that's what we're doing now. But we don't know exactly how to define volume yet. So it's a little bit early. And so sometimes I'm one of the old school guys that still says it's helpful to do a bone scan to help me if they're on the edge. I mean, if they have like 2 or 3 bone mets on a PSA PET scan, I don't need to think too hard. They're not going to have high volume disease. I'm probably not going to give chemotherapy there. But then I have to ask myself, would they even have metastatic disease by conventional imaging, or would they be the old school biochemical recurrence? So these are some of the factors that we're facing right now.
And not to overthink it, to your point, this is it's not a hard line at 4 mets, right? This is really just most of those patients on average had 10 to 20 mets. So this is more a little bit of high volume disease. You know it when you see it. Mm-hmm. Yeah, excellent. Now, let's just, on this other case, I think, again, Dr. Vizazi alluded to this, Lenny, patients that had local therapy progress. Maybe they've got a rapidly rising PSA now, but there's no obvious sites of metastasis. We get a PET scan. Maybe we see a little something in there, again, to Evan's point, it's probably not something we're worried about we're going to even see on bone scan. How do you think about that patient now? We mentioned the EMBARK study. How does that data and the sort of evolving landscape influence how you treat these folks?
So I do think, I noticed down here we include continuous versus intermittent therapy. I think for this particular setting, intermittent therapy is really not the way to go. And I think, a lot of our doubling times that we look at are less than 9 to 12 months when it depends on how aggressive. So when you say rapid doubling time with local therapy, if it's less than 9 months, you really need to up and you need to intensify. If that doubling time is longer than 9 to 12 months, then you may be able to go with doublet therapy and start with that and then up it as needed. But again, I think the standard of care, as we're talking about right now for this man, is really the doublet therapy with ADT and another androgen receptor pathway blocker of some type.
Yeah, it's really fascinating. We started in the chemo refractory castrate-resistant setting with these AR pathway inhibitors and moved them incrementally up, all the way up to this essentially kind of quote-unquote non-metastatic setting. And every time they've proven positive. Every time we test the combination hormonal therapy against ADT alone, it wins. And, right now we have the trials going on with radiation therapy in high-risk disease, and we're anticipating that too. So I think it's becoming, sort of our new standard is ADT plus AR pathway inhibitor. We're maybe not there in every setting, the low PSA doubling, slow doubling times, but more and more we're seeing for patients with aggressive disease. That's the way to think about this. Okay, so we have another case here. Lenny, do you want to present this one?
So this is a recent patient we saw. He's a 75-year-old cardiologist, pretty healthy, no significant family history, benign rectal exam. He read the literature over the years, and as a physician basically said, PSA is not worth it, doesn't work for screening. He had worsening lower urinary tract symptoms. It was started by his PCP on tamsulosin. Really didn't change his symptoms much. The PCP put him on finasteride, and he came in, and his PSA was 8.7. They followed him for a while, and finally he got to us with a PSA of now 14 on finasteride. We discussed with him, got an MRI. We had a PIRADS lesion. We were able to biopsy him, transperineal, and I think everyone knows that transperineal biopsy is really taken over in the United States as the way to go. All grade group 5 cancer, most of the cores pretty significantly involved. We went ahead and got, of course, the PSMA PET scan on him, and we saw activity not only in the prostate, as you can see in the one panel, but also we found one large iliac node. And when we sat down in our multidisciplinary clinic, our radiation oncologist, our radiologist, although the original read was multiple small retroperitoneal nodes, we weren't sure they were really positive, but nonetheless, due to the size of the lymph nodes and his PSA level, we decreed him as high-volume metastatic hormone-sensitive prostate cancer. He had a relatively normal testosterone, had negative germline testing. So again, if we follow the guidelines, and treat him as a high-volume disease. Again, whether or not those multiple retroperitoneal nodes were positive, certainly his PSA on finasteride. You got to realize that was 14, and if we double it, theoretically it goes up to 30. So again, he was initiated a couple of weeks ago on the triplet therapy using docetaxel, and we went ahead and put him on darolutamide.
Okay, great. Thank you. Thank you for that. And so let's talk now, shifting gears a little bit to the future. And this is, I think, as Dr. Fizazi said, over the next couple of years. This isn't like pie-in-the-sky future. We're going to talk a little bit about PARP inhibition. There are trials that have been completed. There are trials that are near completion. We're going to have readouts in the next year or two regarding these studies. And we're anticipating, again, for biomarker-selected patients, as Dr. Gomella pointed out, that these very well could be positive results. So here to put this into some perspective, again, our online virtual consultants.
So back to our to-do list and some questions about the concept of, in the future, adding targeted treatment in patients with metastatic hormone-sensitive prostate cancer, and specifically PARP inhibitors, particularly for patients with somatic and germline BRCA mutations.
We're routinely using PARP inhibitors in castration-resistant disease. This year, or soon after, we should see the readouts from large phase 3 trials testing the very same drugs, but earlier in the course of a disease in metastatic castration-sensitive disease, especially in patients with BRCA alterations. So hopefully we'll see good news. But if so, how do you think you will be using these drugs? Do you fear the onset of myelodysplasia or leukemia if you're using this drug for a long time? And what about GI tolerance?
What happens if you have a patient with metastatic hormone-sensitive prostate cancer as a medical oncologist, and they've got a BRCA2 germline mutation and want to get a PARP inhibitor? Would you or have you done it?
I have done it. I was very careful to state that it's not currently FDA approved. It's a little bit difficult to get it reimbursed, but not impossible. And it makes rational sense. And even if my patient was not a medical oncologist, I have had other very intelligent patients requesting that, especially with a BRCA2 mutation, especially with a germline. And I've done it a handful of times. The challenge is that patient would be expected to respond to ADT plus ARPI anyway, so you never really know with a single patient N of 1 if the PARP inhibitor is adding something other than the fact that their progression-free survival will hopefully be really prolonged.
How do you think people are going to handle duration of therapy? You think they're really going to try to keep them on 2, 3, 4 years?
I think that's going to be tough. I think that the targeted agents, after about 24 months, it will be very, very tough to maintain those at full doses. And I'm wondering whether the hormone therapy itself might be continued, possibly even the ARPI, but maybe the targeted agent might be stopped after 2 years or 18 months. Of course, we don't have the data to back that up, but I think it will be done.
Okay, great. So we're just a little bit behind schedule, so we're going to go through these, a little bit quicker here. So the outcomes on phase 3 trials, would that prompt you to employ these in this setting? What level of evidence do you need? Is it hazard ratios? Is it the median RPFS, or is it OS? What are you looking for in these trials, Evan?
Yeah, we're talking about the TALPRO and the Amplitude studies there. We have to see those trials read out. There are toxicities to PARP inhibitors. I'm going to want to see reasonable hazard ratios like 0.75 or below, something like that. Personally, I'd love to see OS because you just never know. If you have an agent, when you use it earlier, now we have examples, as you mentioned with the ARPIs, the earlier you use them, you keep getting benefit. We haven't seen that yet with the PARP inhibitors. We might get the same thing, but there are toxicities with long-term use, like MDS and AML, so we have to be careful about that. So, of course, I'd love to see OS. PFS might be enough if it's really, really overwhelmingly awesome.
Yeah, it's going to be tough now. You got to keep in perspective. The first trials were against ADT alone. Now we've got really active therapy as our control arm, right? So now we've pushed the bar out further. It's going to be harder to change that hazard ratio when you have a longer survival in your control arm. So I think 0.75, that seems like a good number to me. So Lenny, if PARP inhibitors are eventually reached in the clinic for MSSPC, how do you see sort of the strategy versus sort of the traditional triplets with docetaxel, ADT, and an AR pathway inhibitor?
Well, I think we all know that a lot of patients don't like docetaxel. They don't like the discussion of chemotherapy, even though it's wonderful. There's no question the term I like to use is a shift to the left. All these things that work in metastatic castrate-resistant prostate cancer are now moving earlier and earlier in clinical trials. I think what we're going to have to see is that we know from a lot of the PARP inhibitor trials that patients without germline or somatic mutated genes actually do respond. I think as we move the PARP inhibitors back, we're going to actually figure out for metastatic hormone-sensitive prostate cancer, are we going to need to do germline or somatic testing to decide how they fit in? So again, we got to see how the trials all shake out probably over the next couple of years. But look, just like we've added on other agents, who knows, it's like the regimens we have for testicular cancer now that have four different agents, or your other malignancies have 4 agents. Maybe we'll get to the point where if the tolerability of the side effects is not bad, we might have multiple agents to go to a quadruple approach for some patients.
I mean, more choices isn't a bad thing, but it does require a little more nuanced thinking. So this is a totally unfair question, so I'm going to give it to Evan. So say we get PARP inhibitors approved in this space now. You're seeing patients treated for years. There's all this concern about, cumulative risk of MDS. These are older men sometimes, and even AML. Evan, what's your threshold here? What are you looking for? And, is there any stopping, along the way?
Yeah, I mean, I kind of agree with Emmanuel. I do think that we probably should stop along the way. As we treatment intensify more and more and we show benefit, the one thing we need to start asking ourselves are about mechanisms of de-intensification at the same time. So I'm going to refer back to something Kareem said earlier, is what about on treatment if you get that undetectable PSA 6 to 9 months out? That might be a good patient population with a good prognosis that we might start to re-explore intermittent therapies again. And so not just with PARP inhibitors, but even with ARPIs, and can we get people into a good place and then de-intensify them. So intensify them up front and then de-intensify. That's going to require clinical trials.
It is.
But I think that's the next step.
Yeah. And more markers, right?
Right.
PSA alone may not be telling.
And I do think as urologists we get a little bit nervous about, myelodysplastic and AML and things like that.
Yeah.
That is more in your, in medical oncology's area.
They scare us too, Lenny. So do you want to present your next case?
Another real-world patient that we've seen over the last 6 months, 59-year-old gentleman, went to his PCP for his routine follow-up, no specific complaints. He actually saw an ad on TV during a prostate cancer awareness last September and wanted to know about a PSA test. And again, a lot of PCPs are stuck in that world of, do I do a PSA or not do a PSA? He had a PSA. His first one was 38. Repeat was 41. So it was a real elevation. We did not see this patient. He was treated outside of our cancer center. No MRI was done. He just directly to a prostate biopsy, Gleason 7, most of the cores. No soft tissue or visceral mets. He did have a positive bone scan in the lumbar spine and a right ischial lesion. Both of them consistent with metastatic prostate cancer. And again, where this man was treated was not in a large cancer-centric community. PSMA testing was not done. The local urologist started him on ADT with Leuprolide and then refers to medical oncology for further management. So when the medical oncologist saw him, did a very detailed family history, identified hereditary colon and prostate cancer, did do germline testing, had a pathogenic BRCA2 mutation. At that point, somatic testing was not done. This particular patient wanted to do a clinical trial because it was very interesting that the same advertisement talked about PSA screening and clinical trial participation. Here's just some of the trials that were eligible for this patient. But what I want to do, just make the point about biomarkers, and certainly we're going to talk more about this later with P10. But if you look at this patient, his options for some clinical trials are biomarker-derived. The DDR mutations with the TALAPO3, the HR mutations with amplitude, and the EVAPAR with also with the HRR mutation and non-HRR mutations. And again, PSMA positive is another biomarker that he could be potential for. Again, this is just showing that if we're really serious about getting our patients on clinical trials, and all the advancements that we have made the last 10 years are all based on amazing clinical trials. So we want to continue those clinical trials going into the future. But biomarker-specific indications for drugs in the future are going to be part of our standard of care.
That's great. That's great. So let's move on to Module 2 now. Now we're going to get into this story around P10 and AKT, and you know, we'll follow through on some of the data, why this is important. But Evan, why don't you set the landscape for us with the clinical implications and appropriate strategies?
All right, great. So there's a lot of stuff to cover, but we're going to blast through this because we're going to make sure we get you out on time. We've got a busy meeting here today. So I'm just going to talk a little bit about P10 as a biomarker and the fact that tumor suppressor genes, we know, are a poor prognostic marker in prostate cancer. And so when you look at what the common tumor suppressor genes that we see in prostate cancer are, they tend to be things like P53, RB1, cell cycle-related things, and then activation of the PI3 kinase pathway, which is, you know, right downstream regulated by P10. And these have strong correlations with survival outcomes, as we've been able to see radiographic progression-free survival and overall survival is all worse when you have at least one tumor suppressor gene alteration, and there are some studies out there that show that there's cooperativity. If you have 2 out of 3 of those that I mentioned, potentially even worse outcomes out there. So let's focus on P10. So here's just a diagram of P10. We know that, you know, the PI3 kinase pathway can be activated by multiple growth factor receptors. You know, upstream, we think about other diseases like lung cancer, EGFR, PI3 kinase pathway is all, you know, turned on by these growth factor receptors when the ligand binds to it. And downstream of that is AKT. Now, P10 is a negative regulator. So when P10 is lost, then you get PIP3, which then stimulates upregulation of PI3 kinase and pushes down that pathway as well. And again, you know, this is something that, you know, when you have loss of other tumor suppressors, now you kind of have synergistic bad actor, bad player cancers that way. So how do we assess for P10? There's multiple different ways, but the most common way, tried and true way, is through immunohistochemistry. And here's just some pictures, diagrams. In particular, I like the one with the homogeneous P10 loss. You can see those glands where really it's completely null staining. You don't see any staining at all. And we're looking for lack of staining of P10 to define a P10 null status. Now, there are gradations of how much you lose, and that's why there's heterogeneous P10 loss and homogeneous P10 loss. But this is a potential biomarker. Of course, many of us do next-generation sequencing as well. But the thing about that is that there are other mechanisms that can lead to loss of protein expression of P10. And so for now, we're still focused on P10 immunohistochemistry. So when you look at P10 loss, prostate cancer is one of the cancers that is most commonly lost P10. And this occurs even early on in localized prostate cancer. It can be up to half of cases, depending upon which series you look at. In castration-resistant prostate cancer, it may be around 30%. It may have more implications there in the metastatic castration-resistant prostate cancer into leading to a worse prognosis and aggressive nature of prostate cancer. And here's just some prognostic data. This analysis looked at correlation with things like metastatic disease volume. It didn't correlate with, PTEN loss didn't correlate with Gleason score, but it did correlate with metastatic disease volume, whether it's low or high volume of metastatic disease. Now, I mentioned that there can be cooperation between PTEN and other tumor suppressor genes loss, but there's also cooperation between PTEN, PI3 kinase pathway, and the androgen receptor pathway. So it's reciprocal activation. So basically what ends up happening is if you have upregulation of the AR signaling pathway, and you block it, what ends up happening is you end up with upregulating the PI3 kinase pathway and vice versa. So there were some thoughts early on that you need to block both pathways simultaneously to really get good effect. And here's just some more prognostic data, some real-world analysis saying that if you lose PTEN, you have worse overall survival outcomes here. Now, one thing, we know that there's a worse outcome for these patients. There's also some data, preclinical data, that shows that these cells that have these tumor suppressor genes that are lost may actually respond better to docetaxel chemotherapy. So the Alliance group is asking in the upcoming ASPIRE trial a really good question, which is they're taking the high-volume disease patients or de novo low-volume disease patients, and they're randomizing them to ADT apalutamide with or without docetaxel. Because we know that all the triplet therapy studies use ADT docetaxel as the control. Do we really need the docetaxel? What we need is a study with the ARPI as the control. And as part of this study, they're doing sequencing and they're looking at P10, P53, and RB1 loss with the thought that that population of patients are going to be the ones that likely benefit the most from docetaxel. So we'll wait to see the results of that study. Now, a little bit more about what's been done. Lenny talked a little bit about the 281, Capitello 281 study that we're waiting to see the results from. That's been read out, press released as positive. But what led to that? This was a phase 1 trial of combination of abiraterone and capivasertib for MCRPC patients who have had at least one line of systemic therapy, and they could have had prior enzalutamide, just not in the last 8 weeks. So we know abiraterone doesn't work so well after enzalutamide, so it's really addition to capivasertib. And what we see are the side effects that we expect to see with capivasertib, an AKT inhibitor, which are things like diarrhea, things like rash, fatigue, etc. But you can see by the spider plots on the right that there are some patients that had PSA declines and durable PSA declines that stayed really, really low there. And then the next question is, what about combination of capivasertib with docetaxel for the MCRPC state? There was the PROCADE study. This was a phase 2 study, and capivasertib with docetaxel had a median OS of 25 months versus docetaxel with placebo, which was 20 months. So this led to the randomized phase 3 Capitello 280 study that is fully accrued. It's basically for patients you're going to give chemotherapy to for MCRPC, docetaxel with or without capivasertib, or with against docetaxel and placebo. It's placebo-controlled. So we eagerly await the results of that study that has yet to read out. And I'll just quickly summarize here my talk, which is that metastatic hormone-sensitive patients, you should really at a minimum give them a doublet, ADT, ARPI. If you're fit for docetaxel, and especially if you have de novo high-volume disease, consider a triplet. But these tumor suppressor genes, P10, P53, RB, poor prognostic factors. It's unclear whether P10 deficiency predisposes to better outcomes with docetaxel. It may, and we're looking at that. And there's early data that shows promise for patients with P10 deficiency and AKT inhibitors like capivasertib. We're going to see results from the randomized phase 3 trial soon. And then there's other classes of agents out there, as mentioned, like PSMA positivity and the PSMA addition trial. So looking at lutetium-617 PSMA and looking at PARP inhibitors, as we've talked about. So I think we have a changing world in the near future. And I'll turn it back over to Dan. He asked me to shave a couple minutes. I shaved 2.5 minutes.
You did. All right. I'll take it. Well done. We'll give him a quick applause. Quick. That's enough. Okay. So back to our consulting positions now. As you heard, Dr. Hope Rugo is an expert in breast cancer, where Cappy's already FDA approved, and so we'll get her perspective and also kind of questions we should be thinking about. So let's roll the tape.
So now we visit with Dr. Rugo, who with her colleagues in November 2023, with the approval of capivasertib with fulvestrant in patients with metastatic hormone receptor-positive breast cancer with either a PIK3CA, AKT1, or PTEN alteration, based on the Capitella 219 trial, quickly brought general medical oncologists up to speed on the ins and outs of therapy with this agent, and she was fascinated to hear about the recent press release from the phase 3 Capitella 281 trial, stating that this agent, now in combination with abiraterone prednisone in patients with PTEN-deficient prostate cancer, has met a key trial endpoint of radiographic PFS advantage. I asked Dr. Rugo to share her experiences in breast cancer and to query the faculty on the stage about what looks to be an exciting development in prostate cancer.
One of the questions for my colleagues working in prostate cancer is if you didn't have anything to biopsy other than sclerotic bone mets, which are really tough to get information out of reliably, would you prefer to do ctDNA with the risk that you would miss some people with PTEN loss? Would you go back to the original tissue from the first diagnosis if a patient had surgery, or a biopsy? Because a lot of patients now have radiation as their primary treatment.
Okay, good question. So, Evan, I mean, you covered this subject. So, what's your strategy for detection of PTEN deficiency, and assuming that we're going to have a therapeutic intervention to follow that?
Yeah, I mean, I'm always a fan of real-time tissue if you can do it. Of course, you can do ctDNA, but you're going to miss some of the things. Now, the thing to remember is, though, that of these tumor suppressor genes that I talked about, PTEN is the one that probably does occur earliest. Mm-hmm. And so P53RB are kind of more late events and really poor prognostic markers. But PTEN you can get early on, and the fact that, it occurs in maybe 40-50% early on and 30% or so in MCRPC means maybe we got lucky and cured some of those patients early on, but the majority of them that had PTEN loss kind of had disease that recurred. Yeah. And so, again, if I can't get real-time tissue, then I don't have a problem with trying to go back to archival tissue and testing for PTEN.
Sure. Lenny?
Can I make one comment about PTEN staining? A lot of urologists the last 5 years would get PTEN staining, and it would just be positive or negative. I'm happy to see that you showed that there's now gradation. Yeah. And again, it didn't have any utility other than giving supportive information. This patient had prostate cancer. But I'm happy to see that we now are getting more granular on exactly how extensive the PTEN deficiency might be.
That's exactly right. That's exactly, and we'll look for that from our pathologists, in their reports and things like that. So, thinking ahead now, right now, where we stand, 2025, Capitella 281, this trial with abiraterone and capi versus abiraterone, hormone-sensitive prostate cancer. It's a positive PFS. There's a trend with OS, but there's nothing statistical there yet. The study is maturing. What are you looking for here, Evan, now in this context against ADT and abiraterone? What's your hazard ratio here? What are you thinking is going to move the needle?
You keep hitting me with these hazard ratios that I have to make up, but I said 0.75 before. I'll
you're staying with that. You're staying with that.
I mean, I like it when it's 0.75. 25% reduction in the risk.
Lenny, you've got patients that can't get chemotherapy, right? I mean, not everyone can get it. I mean, do you have a lower threshold here?
I will tell you, I think the term of hazard ratios is in the vernacular of medical oncologists.
Yes.
I don't think I've recently heard a urologist give a talk about a hazard ratio, so I would leave that to your domain. It's either going to work or not going to work, and is it going to work better than what we have currently?
So positive p-value. Yeah. And you're sold.
That's good. With p-value, we're okay.
You're okay with p-value.
We're okay with p-value.
You like that? Okay. All right. Good. All right. So now we've got some data. I mean, this is sort of more real-world data, but it's data that suggests there are populations of patients that maybe benefit a little bit more from AR inhibitors than they do from abiraterone, an androgen biosynthesis inhibitor. I mean, this drug, capi, would be tied to abiraterone. Does that affect your thinking in any way here, Evan?
No.
I see you shaking the head.
That's from the stopgap data that was recently presented at GU ASCO, which is kind of a meta-analysis looking at a lot of data, and they had all these different forest plots. And yeah, it looked a little bit worse with abiraterone for the older patients. But again, older patients also, abiraterone is known to have some cardiovascular effects, and older patients might be at higher risk for that. But I'm not deterred by that data, which is one subgroup and a meta-analysis. It doesn't change my practice. It's just something that I'd be more careful of. Of course, when my patient has a history of heart failure and a depressed ejection fraction, I'm not going to use abiraterone then. So just things to consider.
Yeah. So I think that's fair. But now, what about docetaxel, Lenny? Now, you talked about this. You've recommended, you got patients you're giving the triplet to. Now you get somebody who has a PTEN deficiency, but they got high volume disease. How do you kind of weigh the docetaxel against the historical, the triplet against the historical ADT and docetaxel data versus this data, which would be against ADT and an AR pathway inhibitors? Evan said really the kind of control arm we're looking for. How do you balance these two, and how would you choose?
The challenge that we have as a urologist is that the Capitello trial has really not gotten out there among
we don't know it yet. Right.
Yeah. We really don't. We barely understand that trial's out there. There's so many different trials.
So we're looking ahead.
But
we're saying it's a positive study. It met that hazard ratio issue. Yeah.
I will tell you that a lot of urologists in their practice setting will jump on this as an oral agent.
Yeah.
That's a big thing, as you know, for urologists, is the ability for a lot of urologists, particularly in large group practices who have in-office pharmacies, to give oral agents. So again, as we mentioned earlier, patients are not happy when you mention chemotherapy. And again, I'm going to have to learn a lot more about the side effect profile of the agents.
And that's what we're going to cover next. It's a great segue because I think a lot of this really does come down to level of comfort. And with any new drug, any new target mechanism, there's going to be questions around that. Before we do, I have a case I'll just share with you all. This is, a case, 65-year-old patient. Real case came in to see me, had presented with bone pain in January 2025, but in November of 24, he had a PSA of 5.16, and all his prior years, his PSA had been less than 1. So just in November, it jumped up, and probably even before he could really act on that with the holidays and everything, he had bone pain. In January, his PSA was 33.9. True case. Got biopsies done, multiple cores, Gleason 4s and 5s. Grade groups 4s and 5s. So high grade disease, gets this bone scan and has just diffuse bone mets. Evan, how many bone mets is that? Can you count that for me?
A lot. High volume.
High volume. You know it when you see it. That's what we're talking about. Exactly. So the patient started on Urologic, and he comes in to see me, and before I can even get the tissue, because it's outside tissue, I send a garden, and I get it back a week later. It's fast, super fast. And, I know this is going to be a positive. I don't know if it's going to have mutations, but I know he's got circulating tumor DNA. We see he's got an alteration in RB that may or may not be malignant. He's got a CDK6 alteration, and he's got a PI3 kinase inhibitor and amplification. So there's a couple of amplifications here with potential significance. Something's driving this cancer. Something woke this thing up. Very angry. We get a scan. He's got, obviously, there's diffuse disease. No soft tissue disease. Bone-only disease. So what would you offer? Lenny, is a high-volume guy? What do you think?
Well, again, we bring these gentlemen into our multidisciplinary clinic. We're medical oncology, radiation oncology, urology at the same time. We always go for clinical trials and, certainly push clinical trials. But again, he looks like a lot of his Guardian doesn't look like we have FDA actionable agents at this time.
Yes, amplifications. It's PI3, not P10.
But again, we don't have a biomarker that tells us this what to use. So again, he looks like the type of guy that would need, in my book, he's triplet therapy, if he was okay with that.
And that's exactly what we did. But what if we had Capitello 281 data? What if we had the drug? Is this, Evan, somebody you'd consider based on that biology? Now, it's not PTEN, but it's the same pathway.
Yeah.
You extrapolate?
I mean, I'd consider, and he's kind of what I talked about earlier with cooperativity. I mean, he's got cell cycle, he's got the PIK3CA, he's got both, alterations going there. I mean, I'll be honest with you, I would probably still lean towards giving him triplet therapy with docetaxel here because he's got all the machinery to say go, and those cells want to divide. I would like to give chemotherapy to this guy. But
I look at this as somebody whose disease just taken off. There's a single biology driving that, right? This isn't just sort of lots of different types, right? This is something driving it, and all of our signals pointing to PI3 kinase. And to me, this is the only opportunity to use an AKT inhibitor. We can do docetaxel later, but if I don't give them, if we get that indication in this space, it's only going to be in this space. It's not going to be re-challenge it and castrate resistant like all our other drugs have. So to me, it's sort of the one opportunity I would start with that to give them the benefit of the doubt, and knowing we have the opportunity to pivot if we're not getting the results we want. Okay. So what about side effects? Because you brought this up and the scheduled dosing and side effects. Let's hear again from Dr. Rugo about her experience.
While there currently is no available information on the more specific results of the Capitello 281 trial in prostate cancer, if this agent or others in the same class become available in prostate cancer, there will be a critical need to be prepared to safely and effectively treat patients. I asked Dr. Rugo to share her experience in breast cancer, hoping this will be helpful.
Capivasertib, based on the phase 1 data, is given 4 days on, 3 days off, and that allowed suppression of the pathway, but also tolerable toxicity in these initial trials. So in the Capitello 291 trial, we actually had one patient who took the drug continuously and ran into problems with hyperglycemia. And there's been a lot of focus on really helping patients understand how to take the drug. The drug is provided in a blister pack, and each blister pack gives you 1 week of therapy. So that's actually been really easy for my patients. One of the things I think that's really important to know when you're prescribing capivasertib for patients is the common toxicities. And the most common toxicity is diarrhea, which occurs in most patients, and rash. And hyperglycemia is a lot less common, but we'll talk about that also because it's an important thing to be aware of. So in terms of testing for patients, when they first start, you want to get a fasting glucose and a hemoglobin A1C. You want to make sure that a patient has an antidiarrheal agent before they start their capivasertib in case they have early diarrhea. What's interesting about the rash of capivasertib is we can usually start again at the same dose without a recurrent rash. If the rash recurs, then we dose reduce, and patients generally manage very well. I'm telling you all these side effects, but generally patients tolerate the drug really well, and I just had a patient on Capi 291 for almost 3 years and continued to play tennis and, organize her daughter's wedding and travel, etc., and she did very well during that time.
That's great. Okay, so a few more questions. So what do you think about that? We heard diarrhea, we heard rash, we heard hyperglycemia. Lenny, is that doable?
Yeah, it's doable, but again, we get I'm here as the token urologist. We're really very adverse to a lot of these side effect profiles. Some of us are very lucky to have an APP, nurse practitioner or PA that can really know how to handle a lot of these side effect profile. But I think that we get worried about it. Again, a lot of urologists don't give abiraterone because of the prednisone. Even though studies have shown that prednisone does not cause any specific hyperglycemia. So again, I think as we learn more about the side effect profile and how to mitigate it, I think that's where you might see uptake. Again, from the urology side, it's very nice to have the oral agents.
It's a learning curve, and I'll tell you this: intermittent dosing, 4 days on, 3 days off, makes a big difference. And Evan, we do a lot of management of these, rash, diarrhea. What's your approach? Prophylactic approach here, do you think, or how do you manage that?
Absolutely. You just got to be on top of it. You got to get on top of it early. I mean, I analogize the early days of, irinotecan.
Yeah.
We had toxic deaths 5%, but then that's because we didn't know how to get on top of it, and you just had to prophylax and get patients on, on antidiarrheals, Imodium, Lamodal, all the antidiarrheals, even DTO we used back in the day. But once we got on top of that, it was fine. And I think it's the same thing here.
Things will even out. You'll get your dose, and then there'll be kind of a steady state patients will be on. Yeah. Okay, so Evan, you've got a case for us.
All right, so this is a 60-year-old gentleman who presents asymptomatically. Initial screening, PSA is 21. History of obesity, hypertension, hyperlipidemia, no known cardiac disease, ECOG 0. Labs are within normal limits. CT and bone scan have 4 osteoblastic lesions in the thoracic and lumbar spine and 1 in the right acetabulum. Exactly what Dan said you're never going to see. We got to make it hard, right?
Yeah.
Okay, next-gen sequencing reveals no alterations in BRCA or any homologous recombination repair genes. However, the patient's labeled as having PTEN loss. So then we go back and do immunohistochemistry and find that 90% of the prostate tumor cells lack PTEN immunostaining. So this is real PTEN loss. So what treatment should we consider for this patient? ADT alone, ADT plus abiraterone, ADT plus capivasertib, ADT docetaxel, ADT darolutamide docetaxel.
Well, I'll take this one because I've been picking on you. So I think this is the sweet spot for CAPI in this setting because to me this is a patient it's not really high volume. It's kind of pseudo high volume. It's kind of medium volume, medium rare volume. So I kind of look at this as like we don't need the big gun. And to Lane's point, docetaxel it takes a pound of flesh out of people. So if we can get by with something like CAPI, and it's the window. This is the only time we're going to be able to test that biomarker. How much of a driver is it? So I like number 3 here.
Right. So today, this technically fits high volume disease, so ADT darolutamide docetaxel. But tomorrow, ADT Abi capivasertib. This is probably the sweet spot. Like
Exactly. Okay.
Yep. And so anyhow, I think I basically just
covered
said this. Yeah.
Okay. So we want to just one more from Dr. Rugo about hyperglycemia, because that's one that can also kind of throw us off a game a little bit. So just to kind of hear how they do it in breast cancer.
A critical lesson learned by medical oncologists is the surprising, challenging issue of glucose intolerance with agents in this class, particularly the PIK3 inhibitor alpelisib and the new addition, inavolisib. Our CME programs have discussed this topic so frequently, I've been joking that we need to do a Diabetology 101 class for oncologists. Here's a taste of what we've been hearing.
Hyperglycemia is much less common with CAPI than it is with the alpha-specific PI3 kinase inhibitors. We didn't see a lot of hyperglycemia in the phase 3 CAPI 291 trial, but in post-marketing, as well as following these patients on CAPI 291 over time, we've seen a small handful of patients who've had more serious hyperglycemia with even DKA reported, which has been reported with all drugs that target this pathway. So it is really important to check initially, but then it's important to follow the patients. Basically, if you target the PI3 kinase pathway, you're impacting the substrate for insulin. And so even for patients who aren't diabetic to start with, you are going to get hyperglycemia because it essentially causes its relative insulin resistance environment.
Any thoughts about the idea of a patient who has a hemoglobin A1C that's higher than was in the trial to try to lower the hemoglobin A1C, either with a GLP-1 drug or more intensive diabetic support?
Yes, definitely have, because we see these patients who have type 2 diabetes and are poorly controlled. They're not taking their drugs. They're not watching their diet. We need recommendations for how to manage these patients. In the academic setting, have been better able to do e-consults for that and then arrange for the visit. And I think this is possible in community practice as well. We've set up a communication with our endocrinologist to say, okay, when we have somebody whose hemoglobin A1C is high, we need to be able to get a rapid consult for those patients. It's actually worked really well for us. But you do need to have somebody on speed dial who can help you.
That's great. That's really helpful. And just thinking about like this kind of how to get, to your point, Evan, how to get ahead on this. So, how often is this an issue already with our ARPIs and the little prednisone and things like that, Evan? How much are we dealing with it?
I mean, we see it. We see it a reasonable amount, and so that's reasons to work as a multidisciplinary team, work closely with the primary care doctors, with endocrinologists, with those that have really, really tough, glucose management. But this is a common thing.
Yeah, and there's so much more ways of monitoring glucose now, continuous monitoring, the GLP-1s.
Right.
There's a lot more that can be done to manage this. So it's becoming less and less critical, and patients are more and more knowledgeable about this.
But can I ask you a question about the campus, but the trials? The trials have abiraterone and prednisone.
Yes.
Is this isolated to just this drug? If you took this drug outside of the setting of needing abiraterone and steroids, will you still get the same hyperglycemia?
You do. So in the breast study, it's not with prednisone. And they still see it.
You still see it.
You still see it.
Is it worse with the prednisone?
Well, we haven't seen that data yet. So at least in the phase 3 level. So, but we will. We'll have that data. So I'll do a quick case here. Another kind of real case, different from the last. This 80-year-old with, again, type 2 diabetes, some hypertension, lipidemia, a little AFib. Maybe not the best chemo candidate, presents the ED, he's got abdominal pain, he's got retroperitoneal adenopathy, he's got some sclerotic bone lesions, PSAs. And his prostate's enlarged, his PSA's 9, and he gets a CT, numerous lymph nodes, supraclavicular all the way down. He's got multiple, again, probably around 4 bone lesions. His PSA's stable. Gets an FDG PET. They're not thinking prostate cancer with a PSA under 10, and he gets an FDG PET and it lights up. So the biopsy of supraclavicular node comes back prostate cancer, positive prostate cancer, NKX marker. Referred to Duke. His PSA is now up to 15. He's got elevated alk phos that's gone up in the last month. He's got a decreased hemoglobin. Kind of workup do you want? We get, even again, before I can even get the tissue, I send his circulating tumor DNA, and this is what comes back. And look, they already got Cappy on there. What do you think, Evan? Anything? I mean...
this is a tough one. I mean, again, right now, what would I do? I'd do triplet therapy with docetaxel. But in the future, I might think about a capivasertib here in this patient.
Yeah, exactly. Okay. So now I'm going to go over our last module, now the emerging role of AKT inhibition in patients with metastatic hormone-sensitive prostate cancer. A lot of different things we're going to run through here, but some of this Evan covered, so we'll be able to skip through this a little quicker. So he's already talked to us about the P10, PI3 kinase, AKT pathway and the importance and prevalence of this in prostate cancer and the crosstalk. And this is really critical. The reason why the CAPI 281 study is so important is because it's being done in the setting of really hormone sensitivity, where we have the greatest effect of our AR pathway inhibition, and then to be able to block this, PI3 kinase, AKT signaling when the tumor probably needs it the most. And that this is a relevant target. We see this a lot in prostate cancer. He's shown this slide. I'll just point out one difference, though. If you look on the bottom here on the right there, most of the breast cancer alterations are in mutations in PI3K. And in prostate cancer, it's really the loss of P10. So it's sort of just differences in how this pathway is being altered in these two settings, and it's interesting. We see that particularly there shown for prostate cancer, not in a lot of other cancers. And as Evan shown in castrate-resistant disease, there's also prognostic significance in hormone-sensitive disease, albeit less data, but certainly in patients with bone metastasis, you can see there's a worse prognosis with the loss of P10. And it's relative. So if you have a single allele loss versus double, you can see this. And that's interesting because a lot of tumor suppressor genes, it's all or nothing. If you've got even a little bit of the tumor suppressor gene, it works. With P10, it seems to be a little more of a relevant marker. And we'll see how that immunohistochemistry kind of pans out in the trial. This is the breast study that really led to the proof of concept that blocking AKT can be clinically beneficial. And as Dr. Rugo alluded to, the Capitello 291 study, a large randomized study, advanced breast cancer patients have previously treated one prior therapy, either hormonal or chemo or both, randomized to either fulvestrant, that's a standard of care AI inhibitor, versus, and that's aromatase inhibitor, not artificial intelligence. versus fulvestrant and capi. And again, placebo-controlled trial. The primary endpoints were dual endpoints. They looked at rPFS in the overall population, and this is the overall population, so including patients that didn't have, a PI3 kinase mutation or AKT mutation or loss of PTEN, and there still was a significant benefit to the addition of that, really a significant hazard ratio there, 0.6. And when you actually focused in the other dual primary endpoint and those with altered AKT pathway, it was even greater. So there's both prognostic and predictive benefit, and it goes beyond just the canonical pathway. This is an important target as well. And there's an overall survival benefit as well, seen both, again, in the overall population, but also and even more so in the selected population. The side effects she covered nicely for us. Again, the diarrhea, a little bit of nausea there. She didn't mention rash, fatigue, things like this. I mean, some of this stuff is really overlapping with fulvestrant, but you can see the issues there. Hyperglycemia pretty far down on the list. So and a lot of that kind of grade 1, grade 2, very little grade 3. So manageable hyperglycemia in the clinical trial. Just to level set, this concept of AKT inhibition is not new to prostate cancer. There was a prior AKT inhibitor called ipatasertib that was studied. It was actually studied all the way to phase 3 in the castrate-resistant setting in patients who got either abiraterone, again in the castrate-resistant setting, or abiraterone plus ipatasertib. And interesting, in the intention to treat population on the right, really no difference. There was a slight signal in the patients with loss of PTEN that you can kind of see it, but it's hard to see. And I think the reason is in this slide here, buried in this slide here. There was a significant amount of toxicity. This was dosed continuously daily. And because of that, we see the sort of grade 3 to 5 adverse events there, and over 50% for the ipatasertib arm. It's a little hard to see. Trust me on it. And you can see here the hyperglycemia rates with the ipatasertib here, just the third one down. Pretty high rates here, 70. Somewhere around 47% had hyperglycemia. Rash at 41%. Diarrhea at almost 80%, so pretty significant toxicities that I think really ultimately may have really compromised the efficacy in those settings. But how does that compare to capi? They're both pan-AKT inhibitors. They have similar affinity and specificity, both with dose at 400 milligrams. They're both orally bioavailable, but ipatasertib has a 45-hour, 2-day half-life, so you can't really wash it out very easily, so they continuously dose it. The capi half-life is 12 hours. So, when you're dosing this, it's BID dosing for 4 days, and then it's 3 days off. You really kind of level set again, so you're kind of hit a steady state, and then you're back off, hit a steady state, you're back off. So it really gives those patients a chance to let their body kind of wash out and prevents that cumulative toxicity that I think really limited some of the dosing. So we've alluded to this study, the capi 281 study, again, biomarker selected in PTEN deficient patients, de novo metastatic hormone-sensitive prostate cancer against an active competitor, abiraterone and ADT, placebo, or capi. The primary endpoint, rPFS by a blinded independent review, and the key secondary endpoints, overall survival. This was the press release just stating that on the top level, you can read the title here, in castrate and hormone-sensitive prostate cancer, it demonstrates significant and clinically meaningful improvement in radiographic progression-free survival. If you look at the second paragraph, overall survival data were immature at the time of the analysis, but it showed an early trend of improvement, and so that's what we're looking for as a key secondary endpoint. Obviously, it's met its first endpoint, and we'll be able to see those results in a future meeting. This study, again, Evan alluded to it, this is in the castrate-resistant setting, kind of where, we saw ipatasertib, struggle a little bit. We'll see how this data pans out as well. This is with docetaxel, and it's been hard to add to docetaxel and beat that. So, but nonetheless, I think it's important to know. So we'll be looking at data in both the castrate-resistant and in the hormone-sensitive setting. So I think in summary, this is an active pathway. I hope we've convinced you that this is a driver of aggressive biology. It's not the only driver, but there's a subset of patients, 25% or so, that this is a driver of that biology. And there's a crosstalk between these pathways. We see it in breast cancer with ER. We see it in prostate cancer with AR. And I think ultimately, how accessible this side effect profile is. It certainly is in breast cancer. We'll see how tolerable that side effect profile is in prostate cancer. And that this will be something to really kind of look for in the future, and then how to weave that into our practice. So just to give a little future perspective on prostate cancer and this changing landscape, we'll go back to Dr. Antonarakis.
Finally, I asked Dr. Antonarakis to query you about your vision for the future of prostate cancer treatment.
One question that I'd love to ask the faculty is, other than PSMA, what are the two most other exciting targets in prostate cancer drug development? The second question would be, we're hearing a lot about bispecific T-cell engagers, also known as BiTEs. In their experience, what is the most promising or encouraging bispecific agent for metastatic CRPC? I would also like to know, what is their opinion of antibody drug conjugates? Boy, we've been hearing about ADCs in breast cancer and bladder cancer for a long time. We are now beginning to hear about ADCs in prostate cancer. In the opinion of the faculty, what targets are the most relevant for ADC therapies in prostate cancer, and which ADCs specifically are the most promising in their minds? In 3 to 5 years, do you think that NGS will be mandatory for every metastatic hormone-sensitive prostate cancer patient? And if yes, how might that influence your first-line MHSPC therapeutic choices?
Great questions, always from Emmanuel. So what potential therapeutic targets are you most excited about in the coming year? Evan, you want to start us out? What are you thinking?
Yeah, it's hard to pick two. He said two, but when it comes to bispecifics, there's, STEAP1 looks promising for bispecifics, KLK2 looks promising for antibody drug conjugates, there's B7H3, there's TROP2. There's a lot of stuff, and I do think that all of them have promise. All of them have shown early promise and are going into later stage studies in the near future. So, and I think they're all worth exploration.
Yeah. A lot of these are deliveries, right? Mm-hmm. But some of these biomarkers are also drivers, mm-hmm. right? And to me, that's sort of what I'm excited about, is really how do we really impact the driver biology? Because that's what we can move early and hopefully really kind of expand our armamentarium. It's not just sort of, a delivery of another cytotoxic. Lenny, what about all the future here? We've talked about AKT inhibitors, but immunotherapies, radiopharmaceuticals, that field is really growing into the space. Where's your head?
Well, it's still nice to see that Sipuleucel T is still floating around out there 15 years later as an immune target for prostate cancer. But one of the things that that we follow at our center is the radiopharmaceuticals, particularly all of the new things like the copper agents and things like that might be more give us more utility. Radium-223 is still out there, but again, it's not used to the same degree it might have been 5 or 6 years ago. But I think personally the radiopharmaceutical agents, because they really do have a lot of potential for immediate symptom relief and things like that, are one of the areas that I think is most interesting.
Evan, you look like you want to say something?
No, I'm just trying to look over the thing.
Okay, all right. No, I completely agree with you, Lenny. I think this it's really a way of precision medicine, right? Of delivering this radiation, which we know this is a radiosensitive tumor. Now we have even more, potent radio approaches, and the approach to be able to deliver that directly to tumor. So here's a future scenario, Dr. Yu, you're going to walk us through.
All right, so this case could have been tougher, but this is 62, still tough. 62-year-old gentleman presents asymptomatic, initial screening PSA 15. No previous medical history, mild hyperlipidemia, some osteoarthritis, ECOG 0, labs are fine. PSMA PET CT finds 6 lesions in the spine, bilateral pelvic retroperitoneal lymphadenopathy, 1 to 2 centimeter range. SUV range is 8 to 26. It's clearly over liver, so this is PSMA PET positive. Next generation sequencing reveals no alterations in BRCA. So, okay, could have been BRCA positive, but didn't make it that way. But there's no other homologous recombination repair gene deficiencies. However, the patient's labeled as having P10 loss by next generation sequencing. All right, so what treatment should we consider for this patient? ADT alone, ADT abiraterone, ADT abiraterone docetaxel, ADT abiraterone capivasertib, or ADT abiraterone lutetium PSMA 617. So really looking at the future state.
Yeah. No, and I think this is really what's, I think Lenny alluded to this. I mean, this is what's exciting about the field, but it's also challenging, right? Because we're getting back to kind of where we were in 2017 to 2020, where we had these AR pathway inhibitors compared to historical control, not to compare to each other. And so we're going to have this again sort of field where we'll have docetaxel, we'll have capi, we'll have Pluvicto, but we'll struggle a little bit with how to compare. My hope is that these are not mutually exclusive strategies, that we start to begin to ask questions about how to layer, sequence approaches like this, because when I think about docetaxel, when I think about lutetium PSMA, these are defined periods of treatment, right? These are anywhere from 4.5 to 9 months, and maybe it doesn't have to be that long. And so there's opportunities to do kind of inductions and then consolidations and other approaches. So I think adaptive approaches and things like that will be things we'll need to study in the future, since we're talking about the future. But looking ahead, to me, I'll go back to the fact that we have a large window for docetaxel therapy. We have a large window for lutetium PSMA. We have a very small window of metastatic hormone-sensitive upfront disease for AKT inhibition in prostate cancer. And if that is a biology driving this is the only opportunity to test that. So I still like number 4 if that data holds true in the clinical trial, because of that opportunity to give something that we wouldn't otherwise be able to hit.
But that's for now, because what if docetaxel capivasertib ends up being positive? So.
There you go. So then you can start extrapolating that combination into these patients as well. Great point. I just want to thank the audience for your participation, for listening in on all this. I hope this was informative. I'd like to thank our sponsor, AZ, for the program, and certainly the Research to Practice team for putting this together. I think, for me, these are, really exciting times, kind of uncertain times, but exciting because of all the evolving landscape that we see. A lot of our fields will hit a point where we just level off for a long time. And we are not at a leveling off period in prostate cancer. And this space of metastatic hormone-sensitive prostate cancer was so quiet for so long. And ARPIs opened that up, not as a final treatment, but as sort of an opportunity now to build off of that. And once you have one active therapy, the opportunity to build additional active therapies really work. And that's what we're seeing here. That's what I hope we see with all of these trials. That's what I hope you keep your minds open to in terms of evolving your practice and get your colleagues to do it. I mean, this is the group that will lead that real-world evidence, that will lead that practice change in the future with this, and then others will follow our lead. So we certainly appreciate you being part of this session. Thank you to my colleagues here, Dr. Evan Yu, Dr. Leonard G Gomella. You guys did great. Really appreciate all the interactions and everything. We'll stick around for any questions that you have for a few minutes, but thank you so much and have a great meeting.